Okay, good morning. So this morning we're talking about polio. So polio is inflammation of the anterior horn cells in the spinal cord, but also the brainstem nuclei that causes destruction of lower motor neuron units. It's caused by the polio virus, which is a single-stranded RNA virus. There's three types, poliovirus 1, 2 and 3, with type 1 being the most common. There's heterotypic immunity between the virus types. So what that means is that exposure to one type of the virus doesn't give complete immunity to all three types. You need to be exposed to all three. And that has implications in vaccination. It's fecal oral transmission. It's only a human reservoir. And the damage to the lower motor neuron units is caused through a few ways. The first is the viral replication and the toxic byproducts that the virus has caused leads to inflammation of the neurons and the surrounding cells. And then these become targets for neutrophils and macrophages that results in death of the neuron. So just quickly epidemiology of it. So polio was endemic pretty much worldwide prior to the 1900s. Children were exposed at a very young age, so typically less than 6 months, and had very few clinical infections because of the passive immunity that was provided by the mother's early exposure and breast milk. The epidemics came to effect when improved sanitation led to that absence of that early exposure. So then children were being exposed at a later age when they were no longer covered by their mother's passive immunity. So one of the largest epidemics on record is the 1952 epidemic in the USA. They had 58,000 cases of polio, over 3,000 deaths, and then 21,000 with residual paralysis. This led to the development of the vaccinations in the 1950s, and I'll come back to that at the end. It's had lasting and significant medical and cultural changes. The bulbar polio effect and respiratory depression led to the wards of the mechanical ventilators. You can see in these pretty typical pictures from the era. This was the birthplace of ICU. The concept of an ICU was born out of these, and the first ICU was in Copenhagen. It also led to rehabilitation medicine, with these patients obviously having ongoing needs for physio, and that was sort of stemmed that field of medicine. It also led to the disability rights movement in the 1950s and 1960s. There was a large number of post-polio survivors that had significant lobbying power. And it's also led to medical philanthropy. So the Polio Eradication program is the largest combination of private and public funding generation. Again, I'll come back to that at the end. So there's a few clinical scenarios that can happen when someone's infected with polio. The vast majority are asymptomatic and it comes to no effect. There's those that have the minor illness, and this is about a 10-day course of viremia with a pyrexia and arthralgias and myalgias. There is an aseptic meningitis. This tends to be a self-limiting condition with no ongoing effects. The paralytic poliomyelitis is the one that we worry about, and this is the one that we're seeing the effects of today. So 1 in 200 patients that are affected with polio have this condition. It's an asymmetric flaccid paralysis, which distinguishes it from a lot of the other clinical conditions that can affect muscles. There is variable recovery, and the mortality rates are interesting in that the younger you get it, the lower the rate of mortality. If you have a look at the table over on the side, you can see it's broken down into paralytic poliomyelitis is broken down into spinal polio, which those that affect the lower motor neurons controlling the limbs, bulbar spinal that affects both the spinal and the brainstem nuclei, and then the bulbar polio. And these are the guys that tend to have trouble with the respiratory drive and phrenic nerve paralysis. So that's where the mortality rate comes in. So paralytic poliomyelitis, it develops usually in the first week after a fever. And fever starts, it's usually the first sign. And the paralysis develops over the next 2 to 3 days. There's preferential destruction of the motor neurons with relative sparing of the sensory nerves. And the weakness will vary between the muscle groups. The clinical picture depends on which motor neurons are affected. So this can result in quadriplegia, the respiratory failure in those where the phrenic nerve is affected. And those that have the bulbar effects can have problems with dysphagia and dysphonia, which can lead to respiratory compromise through problem with secretions. Proximal muscles are affected more so than the distal, and the lower limb more so than the upper limb. There's reduced tone, and this is asymmetric, and the reflexes are decreased, and as I said, the sensory examination is essentially normal. There is a degree of recovery after the initial onset of the paralysis. The majority of this is achieved within the first 6 months, but there have been reports of ongoing recovery to some degree up to 2 years. The problems that result from this is related to muscle imbalance and the resultant joint deformities that come from this, and I'll come back to that as well. So there's a few theories on how the muscles recover after being affected with polio, and sort of go through these three mechanisms. So the first is terminal sprouting, whereby the surviving motor neurons, their axons have a terminal sprouting effect where they re-innervate the orphaned motor myofibers, and each motor unit can be up to 8 times the size of the pre-morbid motor unit. The myofibers also undergo hypertrophy, and this is to try and increase the function and the strength of that muscle. And there's been reports that normal strength can be returned with only 50% of the original motor units. There's also thoughts that the myofibers change from a type 2 to a type 1, and this has been shown on muscle biopsy studies. So these type 2s being the fast switch into the type 1 to the lower, the slower twitch. Post-polio syndrome is a clinical entity that we're seeing more so these days, obviously, rather than the acute infection, particularly in Australia. So this is the onset of functional deterioration after a prolonged period of stability. It affects up to about 40% of polio survivors, and the symptoms come on between 15 and 40 years after that initial infection. It's a clinical diagnosis, and it's diagnosed by new progressive muscle weakness and fatigues and myalgias. There's a few theories again as to how this comes about. It was initially thought to be a reactivation of the virus and a new or second wave essentially of the polio, but that's since been disproven. And the thoughts are that it's failure of these oversized motor units that are fatiguing over time. One of the other thoughts is that the normal physiological decline in muscle strength is exacerbated in already weakened muscles, and so I guess the aging process is just more pronounced in these patients. There's also thought to be influence of disuse wasting. So typically these patients that have survived polio have balance and strength problems, and so therefore are less active than their counterparts. And so the thought is that again, the normal disuse wasting process with age is exacerbated in these patients. One of the important things is that in a lot of literature is that this should be a diagnosis of exclusion, in that you can't assume that a new onset of weakness is related to the polio and other entities should be excluded. So diagnosing polio, largely, especially in the acute setting, it's a clinical diagnosis where you get an acute flaccid paralysis with preservation of sensation, and this is preceded by that prodromal illness. Lumbar punctures have been performed with sampling of the CSF, and this is more so in that aseptic meningitis, and this tends to show a typical meningeal picture. Culturing of the virus, pharyngeal, that's fecal-oral transmission. So pharyngeal secretions and swabs are positive for the first week of the virus, and the stool for up to 4 weeks after. And this positive stool culture, this is the route in which it's spread. You can culture the CSF, however, this is done more so these days with the use of PCRs and things, but it's not the mainstay of the diagnosis. You can use viral titers, but again, this is largely useless in the acute setting. It's more used to monitor the convalescent stage. Nerve conduction studies have been done. Again, the sensory remains normal. The motor neurons are normal or mildly slowed conduction with low to normal amplitudes. So the treatment in the acute phase is patient isolation so as to prevent spreading of it. Complete bed rest, and this has come about that they've shown that the harder you work a muscle in that acute phase, the more damage you do. So symptomatic treatment in terms of analgesia and muscle spasm, but also starting early passive physio to prevent contractures. During the recovery in the convalescent phase, there's increased physiotherapy and strength training and the use of calipers or splinting, not only to prevent contractures but also to allow physio to occur. This is probably something we're dealing with more these days now, is the residual paralysis and the effects that it has. So there's largely 5 types of deformities that can occur. So isolated muscle weakness without deformity. So this is generally treated with tendon transfers in order to restore function. So an example of this is weakness or paralysis of the opponent's pollicis, and using the FDS tendon to restore opposition in the thumb. The other is passive correctable deformity. So these are generally treated with splinting, and these may require tendon transfers. And this is there's 2 ways that this can be achieved. This is either to permanently correct an imbalance in order to prevent further deformities occurring, or to provide a tenodesis in order to overcome gravity. I'll come back to these all a bit more in detail. There's also fixed deformities, and so the principles here are to restore alignment in the joint and in the bone, but also to stabilise the joint. And it's important to remember that some of these deformities can be compensatory, such as the equinus deformity in the foot, in order to allow standing and walking following back knee. You can also have flail joints, and these develop after a balance paralysis, whereby without any muscle pull or tone, there's no ongoing bony deformity. However, it's a difficult joint to manage, so these are typically splintered or arthrodesed. The other consideration is that the vast majority of patients affected by acute polio are those less than 5, and so it has lasting effects on the growing skeleton, because you use that normal muscle tone and activity, which obviously provides feedback for a growing bone. These are typically treated with orthoses or epiphyseodeses in terms of leg length discrepancies. So going to sort of more specific deformities, the trunk deformities, such as the spine, are usually due to pelvic obliquity, and the majority of these are driven from hip pathologies and abduction contractures. The scoliosis is generally a long C-curve. This is probably not the best picture to demonstrate that, and that develops from a imbalance in the trunk muscles. So the treatment is by correcting the cord. So generally it's the hip abduction correction, which is through a division of ITB, and depending on other contractures, anterior capsular release. And the scoliosis is typically treated by fusion. In terms of the hip deformities, these are really quite complex, and the gradual development of muscle imbalance can lead to subluxation of the hip joint, particularly again in that growing skeleton, and there can be lasting effects on the hip joint. So the proximal femora have increased anteversion and drift into coxa-valga, and there can be underdevelopment of the acetabulum. So all of these components need to be addressed when treating these patients in correcting the soft tissue balance, contractures, and then various osteotomies depending on exactly what the patient has. The most common deformity in the hip is the fixed flexion deformity, and this is that frog leg appearance where they have flexion, abduction, and external rotation. And this is typically due to contracture in the iliotibial band and also the hip flexors. So this is treated by releasing these structures, and there is a description of muscle slides, so transferring the line of pull of the soles over to the greater trochanter, so that you don't get that flexion contracture. In terms of knee deformities, there's a few things that can occur. There is well described instability or the flail knee, and this results, as we said earlier, from balance paralysis and weakness of the extensor mechanism. So these are generally treated with knee, ankle, foot orthoses or calipers or arthrodeses. One of the typical presentations is this back knee appearance that this young girl has. And so this is an adaptive posture following quads weakness, whereby hyperextending the knee allows that locking. Over time, this stretches out the posterior structures and develops a fixed equinus in the foot in order to get that plantar grade, or relative plantar grade. So the treatment for this is quite often involves bony correction, and they describe a supracondylar flexion osteotomy, or tenodesis of the capsule or hamstrings. In fixed flexion deformities of the knee, these are generally due to a tight ITB and quads weakness, So these can be treated by division of the hamstrings or transferring the hamstring to the quadriceps to reinforce it, or there's described bony procedures such as a supracondylar extension osteotomy. The foot and ankle deformities are quite complex, and I think it's important to remember that they're progressive too. So they need a treatment option tailored to that particular patient. The most common is the foot drop, and this is due to tib and weakness. And this develops an equinovalgus deformity with resultant clawing of the toes. So the treatment of this initially is an AFO, and then in terms of soft tissue procedures, the first thing to do is get the foot plantigrade, and this can be achieved through serial casting and Achilles lengthening. I should say this is in those that are correctable still, and tendon transfers. So they talk about using the perineal muscles in order to reinforce tibialis anterior. There's also quite often incorrigible deformities that require osteotomies, and obviously this is done at the level of the affected joint. The foot deformities do evolve over time, and depending on which muscles and where the imbalance lies depends on which deformity occurs. So they can be cavavarus, cavavalgus, depending on what's affected. And these more often than not require a combination of both bony and soft tissue procedures or osteotomies to fix those deformities. And there's description of fusion for the flail joints. So I think the most common being a subtalar arthrodesis or a triple fusion in order to get that correct that equinus. The upper limb deformities and the treatment for them are generally aimed at restoring function. So in the shoulder, the deltoid muscle is the most commonly described, and this is treated with a glenohumeral joint fusion. So these patients are fused in a position of 50 degrees abduction with 25 degrees flexion and appropriate adductor release. This is a picture of a young fellow that's had that done. In terms of the elbow, restoration of flexion can be achieved. I found two described techniques. The first is proximalising the common flexor origin on the humerus, and this is to improve that mechanical lever arm for flexion. And the other is a pec major transfer to the biceps tendon. Pronation can be restored using flexor carpi ulnaris and transferring it volarly to the radial border, and conversely supination can be achieved by taking the FCU tendon dorsally to the distal radius. The wrist is generally treated with an arthrodesis, and this is to provide that stable platform to then use the remaining functional muscles as selective tendon transfers to restore finger movement and flexion. Thumb, as we said earlier, the most common affected here is disruption to opponent's pollicis, and this can be restored by using the fourth or the ring finger slip of FDS and transferring this to the base of the first metacarpal. In looking at arthroplasty in patients that have had polio, there was surprisingly very little published data on this. I found several very small case series of patients of sort of 10, 15 joints. There was no large study. These were perhaps the two main ones that I found. So Hoskiller in 2007, this was presented at a JOS meeting, prospectively followed 500 post-polio or patients, polio survivors over a 15-year period. And out of this 500, only 9 needed a total hip and only 10 needed a total knee done. And they reported excellent results in terms of pain and function scores. And interestingly, they had no resultant instability. And I think this is not in line with perhaps other studies that I found. So this other one in Giori, published in JBJS in 2002, this was a retrospective review, and they only had a relatively short-term follow-up. But in their 2 years, of the 16 total knees that they replaced in 15 patients, they had 4 cases of recurrent instability, 2 periprosthetic fractures, a perineal nerve palsy related to correction of a significant valgus deformity, and an avulsion of patella tendon. So this is quickly a table taken from their study, and there's a few things to notice, I guess. So there's a large number of complications for the number of patients they had. I think their follow-up is not very much the short term. But if you look at the order of the cases and the prostheses used, there was a significant trend towards, and the authors recognised that they drifted towards using more constrained prostheses because of their early instability problems. And so this is sort of some of the recommendations and I suppose the acknowledgements that these authors had. So the difficulties they found was that it was poor bone quality, and this is again that disuse, osteopenia, and things from a lifetime of poor mobility. They highlighted the importance of a soft tissue balance at the time of the procedure in terms of muscle balances. They had significant problems with ligament laxity, again because of a lifetime of joint deformities. Patella made the exposure quite difficult, they commented. And they found that even those patients that were well balanced after the initial surgery, even in that short 2-year follow-up, there was a recurrence of this hyperextension, despite the use of their constrained and their posterior stabilised prostheses. So they recommended in their discussion at the end that although it's possible, and there are good results published in studies, that arthrodesis is perhaps the preferred method, or using a more constrained prosthesis such as the hinge knee replacement. And that if you are going to do a primary knee, that using the more constrained is the better way to go. So just quickly going through just those, trying to summarise, I guess, those treatment principles. The first thing is to prevent deformity, and this is achieved through physiotherapy and splinting, stabilising flail joints, and this can be done through tenodeses, arthrodeses, or again splinting. Balancing the imbalance, so through tendon releases, tendon lengthening, and tendon transfers. I should say too, one of the difficulties with tendon transfers is obviously when transferring a tendon, just in any other patient, you lose a great power. So it's hard to have hard and fast rules of, in this situation, do this thing, because you need to assess the patient and work out what tendons they have, and through the use of muscle charts, work out which ones will be appropriate, so that once they're transferred, they still have usable strength. So the recommendations have been to use tendons that have at least a 5 or a 4 grade of power. That anything less than this will result in failure. Correcting deformities, so these fixed bony deformities, these can be achieved through osteotomies, arthrodeses, and orthoses to some degree, and ultimately to improve functional ability. So preventing the paralytic muscles from overstretching, or augmenting the action of weak muscles, such as tendon transfers from the hamstrings to the quads. In just general considerations, a lot of the articles talk about these patients being difficult, not just in their surgery, but also in the recovery phase. So they take a long time to heal, and this is related to poor vascularity. They have prolonged recovery time, increased length of stay in hospitals due to mobility problems, and they quite often need gait aids. The anaesthetic considerations is that regional is preferred to general anaesthetic, and that polio muscles are more susceptible to muscle relaxants, so this needs to be considered. And these patients should be followed closely perioperatively because they're at increased risk of apneic events and airway compromise, again related to those weak muscles. So I'll just talk quickly about vaccination, trying to end on a more positive note, I guess. So this was developed in the 1950s, and the first was the oral poliovirus vaccine. This is an attenuated poliovirus. It's the preferred method in developing countries, and this is related to the cost. I think it's 11 cents a dose, 11 US cents per dose. The ease of administration, so most of these patients in the developed countries are being treated by volunteers, not necessarily medical staff. So obviously the oral is preferred over intramuscular injection. There is transmission of the vaccine too, which is quite nice, in that patients that receive the vaccine shed it as they would normally a wild type virus. So that helps develop a herd immunity. The downside of the oral vaccine is this vaccine-associated paralytic poliomyelitis. So as this is an attenuated poliovirus, there is a chance of a reactivation and acute infection from the vaccine. So this has been, the incidence of this is 1 in 900,000 for the first dose of the oral vaccine. They require 3 doses, I should have said, sorry, for seroconversion. or 2 in 1,000 cases of those with B-cell immunodeficiency. So this is considered a contraindication to using the oral vaccine in this patient population. The inactivated polio virus vaccine is what we use in Australia, in America, and this is an intramuscular injection. This also requires 3 doses. You get seroconversion in 93% of patients after 2 doses, and then 100% following 3 doses. So I said also at the start that there's a little heterotypic immunity between the 3 strands. So each of these vaccines are available in a single form or a triple form, because you need to expose patients to all 3 types in order to get that complete immunity. So the polio eradication program, this is a great success, I suppose, of modern medicine. So in 1988, the World Health Assembly resolved to eradicate polio, and this was off the back of the smallpox eradication in 1980. So this is a combined project from the World Health Organization, Rotary International, US CDC, UNICEF, and then the Bill and Melinda Gates Foundation have been big sponsors. There's been 20 million volunteers worldwide providing these vaccines, and they've immunised over 2.5 billion children. So since the introduction of this program in 1998, there's been a 99% decrease worldwide of acute polio infections. In 1988, there were 350,000 cases in 125 endemic countries, and then in 2012, this has been reduced to a reported 223 cases worldwide, and only 3 endemic countries remaining, which I think is pretty amazing. Type 2 polio virus was certified eradicated in 1999, and there's just in these 3 countries now type 1 and type 3 remaining. So this is, I got this from the World Health Organization website, just showing, I suppose, more current data. So globally this year, there's only been 26 cases, and these have all been in endemic regions. If you have a look back in 2012, these 3 cases in non-endemic countries were all imported cases. So patients that have moved from an endemic region to a cleared region. And this is, again, showing just the cases that have been reported this year. So polio in Australia, with the Western Pacific region was certified polio-free in 2000. The peak incidence was in 1938, where we had 39.1 cases per 100,000 patient population. We had significant epidemics in 1956 and 1961. The last confirmed case of wild polio was in 2007 and 1977, and these were both imported cases from Turkey and Pakistan. And we've had 2 cases of the vaccine-associated paralytic polio in 1986 and 1995. This is when we then changed to the inactivated polio virus, the injection. So this is not something we see these days. The vaccination schedule in Australia is that the recommendation is that children are immunised at the 2, 4 and 6 months and then get a booster at 4 years. And so this is included in the schedule with other vaccines at that time. So I just got a reminder there to Dave that his baby's due. And also for the adult population, it's recommended in the American literature that adults get a once-off booster in order to confer lifelong immunity. However, in the Australian immunisation handbook, they recommend 10-yearly booster, and that this should be done for high-risk pet workers, and that this should be done in conjunction with tetanus boosters as a reminder. So I thought that was interesting because it's not something I've seen before of a booster. And of course, FDR was probably the most famous polio survivor.
Brilliant. Really, really good.